and welcome to the Home of Medicine podcast with me, Dr. Amie Burbridge. Today I am joined by...
Hi, Dr. Ben Lovell calling. Thank you for having me again.
Oh, an absolute pleasure. Now, I think what everybody really wants to know, Ben, is how are the shelves getting on?
The shelves are in embryo form. I have just moved house, a couple of months ago. So the shelves in the old house were left behind, shed like an old skin, and I'm waiting for my new shelves to be constructed. So I've been living 2 months, all of my books, all of my babies in cardboard boxes or coffins, as I call them, in a pile in the corner of the room. And my shelves are being built and painted, and they will be up, I think, on the just after the Easter weekend.
Wow.
And then they will be in all their glory. And then, of course, people will be able to take appreciative pictures on Twitter. But I'm very excited.
Yeah, your shelves are a thing of beauty.
I know. And it breaks my heart that I haven't had bookshelves for a while. But they're coming, people. Hang in there. They're coming.
So whilst we're waiting for the shelf pictures on Twitter, everybody can have a listen to the podcast that we're about to do. Fab. Okay, so I think you've got a case for me, haven't you?
I do.
Excellent.
Okay, are you ready?
As ever.
So this is a case of a 24-year-old male who is a Polish gentleman with very minimal English. And he was referred very abruptly by the emergency medicine team to the medical take, saying that he's in resus and he has been fitting continuously now for 30 minutes. And they've given 2 milligrams, then 2 milligrams of IV lorazepam with no effect at all. Anesthetics are on their way. However, the patient doesn't seem to require an airway adjunct at the moment, and his vital signs, all his hemodynamic parameters are really okay apart from mild tachycardia, but he hasn't stopped this fitting activity now for half an hour, and they're asking for medical input and support. And we are just around the corner in Estek, so we all trundle around as an excited team to resus to meet this patient. So any initial thoughts or question marks that you wanted, what occurs to you really when you hear this story?
Okay, I've got a 24-year-old male in resus who's fitting for 30 minutes. So is this seizure activity tonic-clonic seizure activity?
Exactly. So they say it's very dramatic tonic-clonic activity with no awareness, which has waxed and waned over the 30 minutes, but not stopped. And he hasn't sort of woken up at all at any point.
And he's had 2 milligrams of, what was it? Benzodiazepine, which one?
IV Loraz. He's had 2 and 2, so 4 total thus far.
4 total, yeah, okay. So it's quite a lot of lorazepam on board, isn't it? And it hasn't had any effect at all on the seizure activity. Okay, but interestingly, his observations are normal, apart from a mild tachycardia.
Well, when we turned up there and we looked at the monitor and his heart rate was 109, sinus. His blood pressure was 149 over 100. Respiratory rate was 26, and his SATs were actually picking up a very normal trace at 99% peripherally without any need for oxygen. They tried putting oxygen on, but the mask kept slipping off. So they'd left it off, and his SATs were actually maintained normally. Okay.
So he wasn't trying to I know it's just going to sound a strange question, but he wasn't trying to pull the mask off, like an agitation rather than a seizure activity.
Correct. They weren't able to elicit any purposeful movements at all.
Okay. So I guess as soon as I approach, I'm going to go A to E on. I'm going to do an airway, breathe in, circulation, disability, and check everything else really, I guess. Blood glucose?
Blood glucose I have here, and that was on the VBG that came out at 6.2.
Okay, so I always think it's one of those things that often gets forgotten about is what's their blood glucose, because sometimes they can be hypoglycemic that's actually causing the seizure activity. Okay, so that's fine.
Do you remember when you were taught in medical school A, B, C, D, E, F, G? And they said it stood for airway, breathing, circulation. Don't ever forget
glucose. Yeah. Yes.
And
I've just forgotten.
You just remember.
I forgot
it never left. It's funny because that came from a time when you didn't get the glucose handed to you, but you didn't get the fabulous VBG with all the data on. You had to remember to do a CBG separately to that. Whereas now someone hands me the VBG and I've got data coming out of my ears. I've got electrolytes, renal function, and all sorts, but you had to remember to do it. But glucose is a great thing to always keep an eye on because it can change on you.
And I also think that highlights how long ago we qualified, Ben.
Oh, shush.
that we were
I'm 29. We've got no proof to the contrary.
Okay, so actually, I want to know a little bit more about the gentleman. Does he have any ID on him? Does he have any medication on him? Does he have any bottles of alcohol? Do you know where he was found, who he was found by? Are the paramedics there? Any friends? Has he got a phone on him?
Yeah.
So collateral history.
It turned out he was found collapsed in the street, and a concerned passerby called 999. And at that point, there was no epileptiform movement. He was just out. And then after the ambulance arrived and they tried to sit him up and get him into the back of an ambulance for assessment is when the epileptiform movement started. He does have a mobile phone on his person, which is locked. He does have a wallet with some small amounts of cash and a bank card in, which has his name on and confirms his age as being 24 from his some ID, but no contact numbers for a next of kin or anything like that. No drugs or alcohol or any paraphernalia of that kind were found on him either.
Was he, what was his temperature? Was he did he have a high temp, low temp?
It was normal, 37.4. Sorry, 36.4.
36.4. So we've done A to E then. We've made sure that he's stable from that perspective. Obviously he's still fitting. So I'm now worried that he is still fitting, that obviously the longer somebody has seizure activity, the more likely, that can actually have an effect on the brain. But is this a true seizure?
What do you mean? What do you mean?
So, is this an epileptiform seizure that we are witnessing? I'm a little bit stuck, to be honest.
So I'll give you some more data.
Yeah.
We have all of his bloods come back and they're all completely normal. His lactate's normal for what it's worth. And then the question is this status epilepticus, which is obviously a horrendous medical emergency resulting in severe short-term and long-term morbidity and mortality? And do we keep piling in the benzodiazepines or do we start loading on an anti-epileptic medication? Now, my gut is always, if someone has not responded to 2 doses of benzos, it's time to reach for the anti-epileptic drugs.
Okay.
And I do know that people who just keep having benzos after benzos after benzos, eventually you will administer a sort of a staggered general anesthetic, and these people will end up losing an airway and having to go to intensive care and possibly be intubated because they've had like 12 milligrams of Loraz or something, or midazolam on board. So I do like to give, personally, I always give the anti-epileptic medications and load them after the second dose of benzos if that hasn't had an effect, if I think someone's in status. What do you load? How do you load anti-epileptics? Are you still a phenytoin gal or have you switched? You've gone mute.
Sorry, I'm on mute. So I like to use levetiracetam.
Okay. Why? When did you switch and why?
When did I switch? I probably switched when I was a acute medical registrar, probably in the last couple of years. And I'd spent some time in ITU, actually. I did ITU as part of my training. And I found that we tended to use levetiracetam in ITU for seizure activity rather than phenytoin. So it's more experiential use than any evidence. What about yourself?
Because it was Phenny, wasn't it? It was phenytoin all the way until a certain point. And the reason I switched to, shall I give you the honest answer why I switched to levetiracetam? Peer pressure, because everybody else had. And I was following the vogue and the fashion of the time. And it was when I was a registrar as well. And I was never quite clear why we changed. Whereas I think I have a clearer idea now about what the rationale was. Everyone says phenytoin's a dirty old drug, and they're right. It interacts with the medications. It's got long-term side effects. And I noticed, what was the first thing that the neurologist did the next day when they came to review these patients who I'd managed to abort their status epilepticus by loading with phenytoin? They cross-weaned them over to levetiracetam. And I thought, well, rather than have this cross-weaning period, might as well just get it right first and start them on the drug they're never be going to what. But I never found, and I still have never found Keppra. I'm going to say Keppra if that's okay, because it's easier to pronounce than levetiracetam. I've never found Keppra on NICE or a guidance. I don't think it's still first status, but it's something we all do in practice now. Because I think we have compelling evidence that it's as good. The only trial I know of was the Eclipse trial trial, and they showed that Keppra was non-inferior to phenytoin. So I was like, okay, that's good enough for me. It's as good as phenytoin, so let's use it. I guess the only thing going against Keppra is that it costs a fortune. If you ever look up the prices in the
I know. It's
phenytoin
really
versus Keppra.
Yeah, but I have found. Sorry, Ben. You were going to say?
I said I found it's sort of more culturally used, and it's culturally very acceptable. And people tell me that it's better for patients. So yes, I do reach for that now.
Yeah, and I think when I'm in resus now, it seems that levetiracetam is more readily available as well. So if I prescribe phenytoin, I can't get it anyway. It's one of those drugs that sort of come out of favour. So it's a good point, actually. It's like
phenytoin, I feel like needs a cardiac monitor as well. I'm not sure. But yeah,
and you have to do levels.
You've got to do levels, and then no one ever keeps it long term. So have you ever seen anyone load with valproate before? I haven't personally.
Oh, no.
No, neither have I. But apparently you can load with valproate, intravenous sodium valproate. What dose of Keppra do you use?
I can't remember, Ben.
I always had 1.5 grams stuck in my head.
I was just about to say 1.6 grams.
Yeah.
I don't know what. But I'm on maternity leave at the moment, so my brain is fried. So, and I think whenever we are prescribing drugs in that sort of situation, I will always double check the dose, triple check it, quadruple check it, get one of the doctors I'm working with to check it as well, just to make sure I'm giving exactly the right dosing.
Well, I looked it up for this podcast, and actually it's 60 milligrams per kilogram. Okay. I think I've been underdosing them for ages, because that comes out with like 4 grams for a healthily built adult. The max dose you give is 4.5. But I don't know where I got 1.5 from. I feel like maybe one patient was a 1.5 dose, and that stuck in my head, which I guess is the little cognitive glitch that I've had. I don't think anyone's come to harm, but it's funny how things stick in your mind.
It's the same with
doses.
Yeah, it's like magnesium sulfate, isn't it? 2 exactly.
2 grams,
But for some reason I always think 2.4, but I'm like, where's the 0.4 come from? Again, it's one of those cognitive glitches, isn't it, that you're like, I've clearly heard it somewhere. I obviously don't just prescribe random doses. I will always double check to make sure I'm not. Okay, so we've got this 24-year-old man. We're thinking of loading him with Keppra or levetiracetam because he's still fitting.
Yeah.
Has he lost control of his bowels or bladder?
There's been no incontinence, and we've looked around. We can't see any tongue biting or sort of cheek biting, but no, there was no bladder or bowel loss of control. Okay,
so is examination possible of him? So can you actually can you listen to his chest, his heart? Is it possible at all?
Yeah, I mean, his chest sounds clear. His heart sound normal heart sounds. There's no sort of peripheral edema. There is no stonking DVT. His abdomen is non-tender. There's no organomegaly we could appreciate. There was no rashes. There was no sort of infective or vasculitic phenomena. There was no needle injection sites, no clubbing of the nails. So really nothing that jumped out.
So the first thing in this situation is to stabilize the patient, isn't it? And that's what you've been talking about, is to trying to stop this seizure activity, if it is seizure activity. And loading with something like levetiracetam would seem appropriate. I would also, at this point, want to be getting advice, either, like you said, from the intensive care doctors or neurologists.
You're right. Stabilization is paramount. I guess if we were going to be picky, he's kind of stable. He's just very active. But when we say stable, I guess, what do we mean? Do we mean tranquil, or do we mean normal hemodynamic parameters?
So we use that word a lot, don't we? Stable. But actually, what does it mean? So he's hemodynamically stable, isn't he? Because his blood pressure is all normal. But it's this seizure, this fitting, that I don't like. And I'd be very concerned. I would say he's not stable if he's still having this fitting activity. And I'd want to try and eliminate that seizure activity if I could, by trying Keppra and getting some advice from the neurologists if needed. Also, I need to start thinking about what's the cause of this. So I need to be going through my head, what is going on. You said that his bloods were normal, full blood count was okay.
His bloods were all normal, including CRP and white cell counts. Electrolytes were fine as well.
So normally if somebody has prolonged seizure activity, they do tend to have a white cell response. So their neutrophils go up. They sometimes get a lymphocyte count elevation. Lactate, again, debatable whether you should use it for identifying if somebody's having a seizure. But if everything's normal, it's sort of think, okay, this isn't infective. His kidneys are okay. His urea is okay. So he hasn't got sort of like encephalopathy from high urea levels. Has he had any trauma? He was found in the street. So,
no evidence of head trauma on examination. A CT head was requested but had not happened yet because we couldn't. It wasn't safe to transfer to the scanner.
Okay, so trauma is definitely something I'd want to be looking at. And we don't know about his medication. We could try and contact his GP if we know his name, speak to his local GP practice and find out, is he on any regular medication? Does he have any past medical history of note, potentially, that could be maybe?
So I'll tell you what happened next. We drew up the Keppra to load him with Keppra, and he actually stopped fitting. And sort of came around and was able to talk in Polish. And we had a Polish nurse who was able to translate. And he said, he's a very vague historian who said, he sometimes has seizures and no, he doesn't know why. And he's never seen a specialist before and they come and go. And it sort of came out that he has been to a few different A&E departments with seizure attacks and was eventually discharged, and we got the sense that maybe he did not attend follow-up appointments with a neurologist. And then he was admitted for observation. And every time we sort of came to the point where we said, you've been fit-free for a while, he would have another seizure. And they were very similar, these very violent thrashing movements with no real derangement of his hemodynamic parameters. And they seemed to be related to his levels of emotional distress. And a few more observations came out. I have to say, whenever, this is just me, and I'm not going on evidence here, for just talking about my own experience, when I do see someone who has very violent seizures without any derangement in either their biochemistry or in their air, they haven't lost an airway or become hypoxic or done anything weird to their hemodynamics, and they're quite resistant to benzos, I do start asking the questions about whether this is an epileptic seizure or not. And if it's not an epileptic seizure, what I'm asking is this what we now call non-epileptic attacks, which has had lots of different names over the years. They were called pseudo seizures when I was at medical school. I think when I just graduated. And then before that, they were probably called something like dissociative seizures. And then at the turn of the century, they were called hysterical seizures. And now I think we prefer non-epileptic attacks. And I start wondering, and that's when I sort of come up close to the patient and try to see if there's any sort of semiology, any signs that I can pick up as to whether I think this is epileptic or non-epileptic. Do you have any sort of things that you look at, or do you think that not truly diagnosed is definitely one or the other, but makes you favor perhaps one or the other?
So I tend to find with the non-epileptic attacks, which I did work in one particular area of the UK where we used to see a huge number of these, and I do wonder whether it was just one of those things. And it's the movements that I tend to find a lot of thrusting, sort of in the pelvic region, actually, sort of like jumping off the bed. A lot more movement in the non-epileptic attacks rather than the epileptic attacks. Often you could say their name and they would stop, I found. And I found that quite helpful. There wasn't any incontinence, no tongue biting. And if there was tongue biting, it wasn't that typical at the side of the tongue where you tend to expect with epileptic seizures. It was at the front of the tongue. Sometimes as well, when they opened their eyes, they didn't have the eyes rolling back in the head. It was more of a focused eye movement. But again, everybody's very different. And sometimes I think it's the gut instinct that tells you whether it's seizure or non-seizure. And we also used to use mobile EEGs as well.
Yes. So the gold standard is to get an EEG whilst they're actually in an interictal sort of episode. And that's the only way you'll know, video EEG with telemetry. But so I think in acute medicine, we have to use other clues, as you say, and it comes from gut. And I wonder, what is the gut? What is that? And I agree with you. I've got certain things which are never completely diagnostic of one or the other. I'm never going to say, aha, you see this? This means it cannot be a seizure, because anything is possible. But I do collect clues and sort of signs that I sort of run through my gut and then say, I think we're going to find this is going to be non-epileptic in origin. And same as you, if I can change the intensity or the activity of the seizure by interacting with the patient, that's a big one, that you're not conscious if you're having two generalized tonic-clonic seizures. So I always advise people, I come down, I go to the patient, I come down and sort of hold their hand and say into their ear, my name's Ben, I'm the doctor looking after you. Everything's going to be okay. Could you just give my hand a little squeeze just so I know that you can hear me and that you're in there? And they don't usually squeeze the hand, but if that interaction either dramatically decreases or increases the intensity of the activity, that is a strong clue for me that it is non-epileptic in origin. So if they suddenly ramp up or they suddenly calm down, I find that quite telling. And the other thing is, do they have their eyes screwed up really tight and they won't let you open their eyes? To me, that implies a little bit of volitional eye screwing. And I think that people having true epileptic seizures tend to sort of have eyes sort of gently closed or half closed. They're glazed over, not seeing really. That's screwed up. And the thrashing of the head from side to side. I'm on a podcast, people can't see me. I'm dramatically thrashing my head from side to side. That doesn't quite make sense, because why would the electrical activity be going from left, right hemisphere, activating a neck muscle on either side? So these are sort of things, and the same with the legs. If they're sort of alternately bicycling their legs, that doesn't quite make neurological sense to me. So they're the things I sort of look for when I'm interacting with the patient, just to see if I can, and obviously, if they cry out, if they start crying or shouting or screaming, you don't really get that with generalized tonic-clonic epilepsy. You can get these bizarre gelastic seizures where they start laughing or crying, but usually they don't vocalize at all. So I sort of go around collecting clues, Miss Marple-like, and then that helps me sort of decide what I think I'm going to do next. Because what I don't want to do is to give someone who's having non-epileptic seizures too many drugs, because I'm going to harm them. I'm going to actually lead to them being over-sedated and requiring airway adjuncts and maybe admitted to ITU. But it's so hard to tell in the moment. And junior doctors, they say, if I don't know and it's the middle of the night, this is a seizure, an epileptic or non-epileptic attack, what should I do? Then the safest thing often to do is to treat it, keep them fit-free as best you can.
Absolutely.
Until we can get the EEG in the morning. Rather than making a rather brave assumption that this is probably going to be a non-epileptic attack. Let's just leave them to calm down for a while and see what happens. I know experienced physicians will do that, but I appreciate that's quite a brave decision to make, especially out of hours.
I've had, when I've had conversations with neurologists about this as well, who obviously are used to see this a lot more than I do. They often say that somebody who has non-epileptic attacks also has epileptic attacks.
Oh, absolutely, yeah.
So they often have a primary epileptiform disorder, and on top of that, so when you have that, it's like, to make that decision that which type of seizure is this? Is it a non-epileptic attack, or is it an epileptic attack? That is, for me, extremely specialist, and unless I know the patient really well, I'd struggle to make that decision, I think, in the heat of the moment. And I agree with you, I would always treat as a seizure activity until proven otherwise, for the safety of the patient. Conscious of that, I don't want to over-sedate and keep giving benzodiazepines time and time and time again.
Yeah, apparently 30 to 40% of patients with epilepsy also have non-epileptic attacks. And they can be exactly phenotypically identical. I mean, you cannot know which type they're having right now in front of you. Yeah, and that's really hard.
Yeah.
I have had some patients who have had an attack and they've come around and they've sort of said, no, that wasn't an epileptic one. I have pseudo seizures, that in their words, that wasn't, but it's very rare that a patient will have insight into which type of seizure they're going to have as well. Um, when
I
you
had
make, go ahead.
I remember a patient I saw a few years ago. She was in her early 20s at university, and her mum and dad had brought her in, who was having seizure activity. And she'd been in a couple of times, and she was away at university and had been going to A&E departments with the seizure activity. And long conversation with the mum and dad and the patients, numerous investigations. It turned out that actually this was probably more than likely non-epileptic attacks. And what was really interesting in this situation was trying not to over medicalize the seizure activity. And it's that fine line of how, as physicians, do we have the confidence to say, actually, I don't think we need to investigate this or manage this further? Because sometimes you'll see patients who are in this spiral who actually don't have the seizure activity. They don't have a primary epilepsy disorder or secondary epilepsy seizures, but they start on medication, they become medicalized, and then they feel like they have epilepsy.
Mm-hmm.
And
it's hard to undo, isn't it?
It's really challenging.
I actually have there's some numbers here. The average time from your first non-epileptic attack until you get the diagnosis of non-epileptic attack disorder is 6.2 years. And in those 6.2 years, patients often have multiple hospital admissions. They have endless cycles of different anti-epileptic medications with different side effects, including fertility issues for younger people. And whilst it's really important to make the diagnosis because you need to know what you're treating to avoid harm, in fact, it's a therapeutic diagnosis. And about 80% of patients who do have non-epileptic attack disorders have a reduction in their number of attacks and their hospital admission frequency once they are explained the diagnosis and the people around them understand it. So getting the diagnosis is really important to avoid harm, iatrogenic harm, but also in order to give them some kind of understanding and therefore to improve the nature of the actual illness itself. I always, historically, when I was trying to explain it to patients, I always said there are two types of seizures, epileptic and non-epileptic seizures. And in your case, we think they're non-epileptic. And I was actually taught recently that's maybe not the right way to go because that actually blurs the line a little bit too much. And a specialist neurologist who's interested in functional disease says, if you look up the word seizure, by any definition, the definition of seizure is abnormal brain activity. And these people don't have that. So he said, we shouldn't actually use the word seizure. We should use attacks. And it's more medically accurate. And also it just helps disentangle a little bit for everyone's understanding what's actually going on. And seizure, and using the word seizure, it's such a medical term that actually it can over medicalize the issue. What do you think?
I completely agree. I think as an acute physician, like yourself, Ben, I see huge amounts of, I don't really like the term functional disorders. And I do think we over medicalize a lot of people actually. One thing I really find challenging is when you have an individual who's having a non-epileptic seizure attack, and they get, again, it's another bias. It's a visceral bias in that you find that some healthcare staff automatically shun them and say, oh, they're just putting it on, it's fake. I'll just leave them to it. And it, that is something else that I also find challenging because they're not faking it, actually. It is a true condition that they are experiencing. And I do think we need to, I think we over-investigate and I think we over-treat, and I think it's about managing that line, really.
You're right. The worst thing you can do for someone who's having a non-epileptic attack is to surround them by people who are eye-rolling, tutting, and saying, oh, don't worry, they'll tire themselves out eventually.
Yeah, absolutely.
That actually will intensify the attack and it causes more distress. And you're right in what you say, in that a non-epileptic attack is completely outside the patient's sphere of control and it causes them inconvenience, distress. They don't like to be having them. They don't want to have them. I mean, I think probably there is I think there probably is such a thing as a factitious seizure, a literally faked
Yeah.
one, for patients who are trying to get something to happen, where they sort of peek at you with the corner of their eye. But I think they're quite rare. I think, most of them, what we see that aren't epileptic are non-epileptic attacks, and therefore outside the patient's control. And we have to just be so careful what's said at the bedside. We assume they can't hear us, or they're not registering, or we think that we can shame them out of it, saying, come on, all this bloody fuss, come on, enough of this. That has never worked in the history of time. If you're going to have conversations, best have them away from the bed space, because they can still hear you. And anything around the bed space should be supportive and trying to get them to resolve whatever. And I don't understand what the psychological, triggers are for this. I find it fascinating, but it's outside my understanding. But I do know that it's related to emotional distress. So we shouldn't be adding to that, because we're going to be adding to the seizure. Well, what are we going to call it? The attacks. We're going to be making them worse.
And I think you've highlighted an interesting point there when you say, actually, we shouldn't be standing by the patient's bed and talking about them. And I see this happening all the time. It could be any condition, any patient that's presenting into the department, and you see a ward round. And one thing that really annoys me is talking about the patient with the patient there, but not to the patient. So you're talking over the bed about the patient itself, and the patient's just sitting in the middle going, again, nobody can see what I'm doing, but I'm moving my head from side to side. Because actually, I think that's quite disrespectful to the patient, and we really need to engage them in this conversation. But try and be careful of actually what we do say in front of patients.
I think that usually when we're at the patient's bedside, we do have to make a little flip between talking to patient and let's make a medical plan, which the patient obviously must be involved with. So I normally preface it by, okay, we've made a plan, and then I'm just going to go through it with my team now, and then I'll talk, and then I'll talk in jargonese very quickly, and just say, that was just me summarizing so we know what we're doing. Or, sorry, we're just going to talk about you for 1 second, but then I'll come back to you, and then I'll turn to the team and say lots of very, very clever medical terms, and then I'll come back to the page and say, right, what did I mean then? What I meant was, and I try and use that to involve them in, and therefore I'm not trying to simultaneously speak two languages to two people and code switch between the two.
I like that. Yeah, I really like that signposting, actually. I'm going to steal that, because I do struggle. I do struggle sometimes with, like you say, is how do I switch between the two? But actually, signposting to the patient and to whoever's on your ward round that day what you're going to do is a really good point, actually. Really good. I'm going to steal that, Ben. Thank you very much.
Oh, have it.
So if you do have somebody who is having a non-epileptic attack, like this gentleman, what did you do? So how did you manage him?
So we managed it by getting the EEG, proving to the patient, showing them that there's no abnormal activity whilst you're having this attack. And unfortunately, he self-discharged, which seems to be what's been happening around other hospitals. It's very difficult when there's when you're a non-English speaking patient and people are trying to talk to you via, you have to wait for the interpreter, and it doesn't always come through. It's a very isolating experience, but once we eliminated epilepsy as a cause for his attacks, we then knew how to manage them. And there's only one treatment for, how shall I rephrase it, non-epileptic status. And that is just patience and empathy, and just talking to the patient and explaining what's happened to them, and letting it go, letting it end on its own. There's nothing you can really do to stop someone having a non-epileptic attack except show them that kindness and make sure they know they're safe and letting them come out of it. There's no drug we can reach for. There's nothing no therapeutic intervention apart from that very basic stuff.
And I think, that's what we need to do more of, is actually kindness and empathy with our patients, because sometimes people just, want to chat, and feel like they're being listened to. There's obviously something else going on in this gentleman's life and background that is triggering these off. But if they're self-discharge, it's often very hard to really get to the bottom of what's truly leading to this, isn't it? If you haven't got the time with them. Yeah.
And if they're moving from institution to institution, sometimes it's just impossible to join the dots, work out what's been done.
Absolutely. Would you make a referral for this patient to anybody if he had stayed in?
Absolutely, yes.
Mm.
And where I work, we have an amazing, nationally renowned neurology hospital in our trust, and there is a huge specialist in functional disorders who see these
Right.
patients. So we're very fortunate we can make a referral to the functional neurological disorders unit. And they have a very multidisciplinary, multimodal approach to these patients and the patient education and all that sort of thing.
Mm-hmm.
So yeah, that's something that we would definitely do.
That's fantastic that you've got that sort of provision there. I mean, in the absence of that type of service, I guess referral to neurology would be an appropriate way to go.
I think so. And I think neurology, but I think there's also has to be some kind of psychological, psychotherapeutic input as well.
Absolutely.
I don't know what the best psychological intervention would be for this cohort of patients. I don't know there's evidence for CBT, for example, talking therapies in this, but I've got a feeling that has to be a very broad part of the approach to managing these patients long term.
Yeah, absolutely. And I guess it's about giving the patient coping strategies as well, and how to recognize maybe is there warning signs for when an attack's going to start, and how they can ground themselves and stop it from escalating potentially. Really interesting. It's definitely highlighted some points that I wasn't aware of actually. Yeah. What are your 3 key learning points that you want us to take away from this case?
Okay, I guess number 1 would be when someone is having a seizure, it's worth coming up to the patient and just looking and interacting, just to absolutely make sure, or to at least gather evidence that you can then present to your own sort of gut feeling mechanism about whether or not this is epileptic or non-epileptic in origin. Thinking about the loading of an anti-epileptic medication, which one, when would you use it and what dose would you use, I think is important. I think just keep giving recurrent doses of benzos back to back is eventually going to lead to patient harm, and something that could be avoided. And I guess finally, it's about, if you do have someone who has non-epileptic attack disorders, it's about recognizing that for you as a clinician, it is frustrating. It's frustrating when they are taking up your time, when you cannot discharge them, because every time you do, they're taking up a lot of resource. But understanding that it, as frustrating is for you, it is for the patient. They have no control over what's going on either. And what they're looking for in you is someone to be empathetic rather than someone to say, now come on, stop your nonsense. And I have seen both approaches before in my time, and I know which one works and which one doesn't.
There's also a question about driving. So in the UK, if you have seizure activity, then you have to inform the DVLA, which is the Driver Vehicle Licensing Agency, because you've had a seizure. And obviously the risk of having a seizure activity when you're driving can obviously cause harm to yourself and others. I actually don't know what the situation is with non-epileptic attacks and driving.
I think you have to be absolutely certain there is no. You have to first of all be able to clinch the diagnosis with telemetry EEG first of all, and then after that, I think it needs to be a completely specialist decision about is this patient likely to have attacks whilst driving or not, and whether or not they use the same metric, which is are they fit free for a period of time before they can drive again. I don't know. So I don't know how they come to make the decision, but I think if there's any even suggestion they could still be true epilepsy here, they would take it as an epileptic patient.
Absolutely. And it would then, you'd have to give the patient the information about informing DVLA. And that's again is another minefield, isn't it? And that's always a reminder that I have to tell myself is when I saw a patient who's had a blackout or a seizure, to tell them you can't drive. And I often print the information off the DVLA website as well to remind myself and also them. Because it's
don't drive. Don't lock doors, I usually say. If someone's had a first aid, when you're at home, don't lock doors. You know, if you go into the loo, just say, I'm in the loo and shout it out. But don't be behind a locked door. Just or take a bath. You know, be a shower person. And at least you get to the first fit clinic and we know the direction of travel thereafter. But just don't put yourself at a risk of having a fit and we can't get in to help you. Yeah,
that's a really, really good point. Fantastic. Thank you so much for that, Ben.
Thank you very much for having me.
No, it's been really, really interesting. And I've learned a lot, definitely. And thank you also for the signposting. I'm going to use that more when I'm taking histories from my patients.
You're very welcome.
Thank you very much. So thank you to everybody for listening to this episode of the Home of Medicine podcast. Thanks for listening. Goodbye.
Thank you. Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.